So picture this. You've finally gone to the doctor for an incredibly painful, intensely itchy skin issue on a very, very sensitive part of your body.
Right.
They hand you a prescription, you head to the pharmacy, get home, and you open the little cardboard box. You pull out the tube of steroid cream, and right there on the printed warning label, in bold letters, it says, "Do not use on genital skin."
Yeah, which is, I mean, it's the exact opposite of what you want to read when you're already dealing with something so physically and emotionally sensitive.
Exactly. But what if that cream is the exact medication prescribed for a severe genital skin condition? I mean, we need to figure out why doctors are prescribing a medication like betamethasone for a condition like lichen sclerosus when the box explicitly tells you not to.
It's a huge contradiction for patients.
It really is. So, welcome to this deep dive. Today we're unpacking a stack of medical guidelines, dermatology formularies, and clinical research to answer one highly specific but critical question. Does betamethasone actually work for the treatment of lichen sclerosus?
And that warning label you mentioned, it's at the very center of why this condition is so chronically misunderstood and, unfortunately, just massively undertreated.
Yeah.
For anyone navigating this, the stakes are incredibly high. Lichen sclerosus, which we often just call LS, is a chronic autoimmune inflammatory skin condition. It primarily causes these intensely itchy, painful, white, sort of parchment-like patches to form.
Right. And while it can occasionally appear on, like, the torso or breasts, it overwhelmingly targets the genitals. We see it most commonly in women over 50, postmenopause, but, it really doesn't discriminate.
No, not at all.
It affects younger women, men, and even children before puberty.
And the physical impact is just profound. We are not just talking about a mild rash that causes some temporary discomfort.
Right. It's much more severe.
Active lichen sclerosus literally alters the architecture of the human anatomy. In women, the severe scarring can cause the inner lips of the vulva, the labia minora, to just shrink entirely or fuse together. Yeah, it can even bury the clitoris under scar tissue, making it completely invisible and inaccessible.
And for men, it often presents as a severe tightening of the foreskin, a condition called phimosis, which can progress to the point where the foreskin cannot be retracted at all.
Exactly.
The impact on a person's ability to simply go to the bathroom without pain, let alone, engage in intimacy, is devastating.
It's heartbreaking. And there is currently no absolute cure. It operates as a chronic relapsing and remitting condition.
Meaning it flares up.
Right. It flares up with intense severity, and then it can be forced into remission. That is where medical strategy comes into play. You have to halt the progression of that scarring.
Okay, so let's establish the baseline here. If a doctor hands you a tube of betamethasone valerate, usually at a 0.1% concentration, is it actually going to treat your lichen sclerosus?
The short answer is yes. Betamethasone valerate is classified clinically as a potent corticosteroid, so it successfully reduces the autoimmune inflammation and that intense itching.
Okay, good.
However, clinical guidelines generally position it as a second-line treatment or a step-down maintenance therapy.
See, I have a fundamental problem with this step-down idea, though.
How so?
Well, if we know LS is this relentless, incurable condition, taking our foot off the gas and switching to a weaker steroid feels like, I don't know, giving the disease an opening to win, why drop our strongest weapon?
That's a totally fair question, but to answer that, we have to look at what the strongest weapon actually is and how the skin responds to it over time.
Okay.
The undisputed heavyweight champion for an initial severe flare-up of lichen sclerosus is clobetasol propionate, usually at a 0.05% concentration.
Right, the really strong stuff.
Exactly. Clobetasol isn't just potent, it is classified as an ultra-potent steroid.
Right.
When a patient is first diagnosed, the immune system is aggressively attacking the skin's basement membrane. You need that ultra-potent chemical fire hose to stop the tissue damage immediately.
Which makes sense. I mean, clobetasol is the fire hose you use when the house is actively burning down.
Yes.
You blast the flames to save the structure. But once the main fire is out, you don't keep blasting the house with high-pressure water because the water pressure itself will eventually, just destroy the drywall.
That's a perfect analogy.
Right, so you switch to the fire extinguisher you keep in the kitchen to manage the embers. And that's the betamethasone.
That is the perfect mechanical way to view it. Your skin is a living, breathing organ. If you continuously suppress the local immune system with an ultra-potent steroid for years on end without ever taking a break, you do increase the risk of systemic side effects.
Got it.
The clinical guidelines explicitly dictate adjusting the potency of the medication to match the current severity of the disease.
So betamethasone isn't like a demotion. It's a highly tailored tool for specific phases of the disease.
Precisely. It is the ideal solution for long-term maintenance. Once the ultra-potent clobetasol has put the initial fire out, stepping down to potent betamethasone, applying it perhaps just once or twice a week, keeps the disease asleep without constantly overwhelming the tissue.
That makes a lot of sense.
And additionally, some patients simply cannot tolerate ultra-potent steroids. Clobetasol might cause intense burning or contact dermatitis.
Oh, yikes.
Yeah. So for them, betamethasone provides a highly effective alternative that still packs enough punch to control the inflammation without the harsh irritation.
Okay, but even if we establish that betamethasone or clobetasol is the right long-term tool, there is still this massive psychological hurdle to actually using it, which brings us right back to that terrifying package insert.
Yes.
You get this tube, and the paper inside literally screams, "Do not use on genital skin." And everyone has heard their whole lives that using steroids long-term will thin out your skin like fragile tissue paper.
Right, and this specific fear drives the most dangerous clinical paradox in the entire management of lichen sclerosus.
How so?
Well, in normal, healthy individuals, long-term inappropriate use of high-potency topical steroids absolutely can cause skin atrophy, which is the literal thinning of the skin. That is exactly why pharmaceutical companies are legally required to print that general warning on the label.
But the genital skin of someone with active lichen sclerosus is not healthy skin.
Far from it. The inflammation from the autoimmune attack is actively eating away at the healthy tissue architecture. Lichen sclerosus itself severely thins, damages, and scars the skin.
Right, so think of the autoimmune disease as an overzealous demolition crew constantly tearing down or building your skin.
Yes.
A steroid isn't a builder. The steroid is the site manager who comes in and fires the demolition crew.
Exactly.
Once the destructive inflammation stops, your body's natural cellular builders can finally step onto the site, safely lay down new collagen and elastin, and actually thicken the wall back up to normal.
And the clinical evidence proves exactly that. Using potent steroids like betamethasone correctly actually reverses the thinning caused by LS.
Wow, so it does the exact opposite of what people fear.
Right. The fear of the package insert, which is known in medical literature as steroid phobia, causes immense psychological distress. Patients read the label, panic, and either refuse to use the medication or use a microscopic fraction of what they actually need.
They think they're protecting themselves from thinning skin, when in reality, they're just letting the demolition crew run wild.
Exactly. Undertreating active lichen sclerosus is far, far more dangerous to your anatomy than the incredibly rare risk of steroid-induced thinning when the medication is managed properly.
So how do we define managed properly? Because dermatologists don't just say, rub a little bit on and call me in the morning.
No, they definitely shouldn't. The clinical guidance is incredibly specific. It relies on a metric called the fingertip unit, or FTU.
Okay, the FTU, what is that practically speaking?
The fingertip unit standardizes application so patients don't have to guess. If you take a standard tube of ointment, which usually features a 5-millimeter nozzle,
Right.
1 FTU is the length of ointment squeezed from the very tip of an adult index finger down to the first crease of that finger.
Wait, just from the tip to the first joint.
Just that first little segment.
Visually, that looks like almost nothing.
It looks very small, but it equates to precisely 500 milligrams of ointment. And the coverage capability of that 500 milligrams is substantial. One single fingertip unit is formulated to adequately cover an area of skin twice the size of a flat adult handprint, palm and fingers included.
Wait, are you serious? One little line on my finger covers 2 whole handprints.
Yes, 2 whole handprints.
That is wild. I mean, this completely explains why application technique is the single biggest point of failure. People are either slathering it on like body lotion, leading to unnecessary systemic absorption, or they're terrified and using the size of a pinhead, which does absolutely nothing.
Exactly. And the prescribed regimen is really a masterclass in controlled de-escalation.
How does the timeline work?
Well, for a severe flare, clinical guidelines recommend applying that 1 FTU every single night for a month. Then you step down to alternate nights for a month. Finally, you transition to a maintenance dose of twice a week.
So it's like a 3-month intensive boot camp just to evict the demolition crew?
Yes, and physicians monitor this using the 30-gram tube rule.
Oh, what's that?
A standard 30-gram tube of steroid ointment should last a patient roughly 12 weeks during that initial intensive phase and significantly longer during the twice-weekly maintenance phase.
Okay.
If you are burning through more than 30 grams in a 6-month period, that is an immediate red flag.
Right.
It tells the physician that the disease is not under control and you are compensating by over-applying.
Okay, but let's look at the scenario where the patient does everything right.
Yeah.
You master the 500 milligram line. You overcome your steroid phobia. You use the clobetasol for the flare. You step down to betamethasone for maintenance. Wait, let me rephrase. You do all that, but you are still intensely itchy.
Right.
The white patches are spreading. What happens when the architecture of the skin is so damaged that the steroid just seems to fail entirely?
When a patient presents with steroid-resistant symptoms, dermatologists run through a specific troubleshooting hierarchy. The first check is always compliance. Is steroid phobia secretly holding the patient back from using the prescribed FTU?
Right, are they actually using it?
Right, but if compliance is perfect, the next step is ruling out a superimposed infection.
Because you've deliberately suppressed the local immune system with the steroid to stop the autoimmune attack, right?
Right.
You've essentially lowered the shields in that specific area.
Exactly. And when you lower the local shields, you create an incredibly hospitable environment for opportunistic pathogens, particularly fungal infections like candidiasis, commonly known as thrush.
Oh, that makes so much sense.
The betamethasone might actually have the lichen sclerosus perfectly contained, but the patient is in agony because the steroid allowed a yeast infection to bloom across the vulnerable tissue.
So you have to treat the yeast infection with an antifungal rather than just blindly throwing more steroids at the problem.
Yes, exactly.
But what if the shields are down,
Okay.
there's no yeast infection, the diagnosis is absolutely correct, and the disease is just bulldozing right through the medication?
This is where the structural pathways for men and women diverge significantly. For men suffering from severe phimosis, where the foreskin tightens and scars irreparably, the surgical route is highly successful. A circumcision completely removes the diseased tissue. In the vast majority of male cases, the surgical intervention is actually curative. The primary site of the disease is simply gone.
Right. But for women, surgery is a totally different landscape. I mean, you can't just remove the tissue and call it cured.
No, absolutely not. And in fact, surgery for women is rarely advised as a primary treatment. The pathology is just frustratingly complex.
Why is that?
If a surgeon excises the white scarred patches on the vulva, the lichen sclerosus almost always recurs directly on top of the fresh surgical scars.
Oh, that's incredibly frustrating.
It is. Therefore, surgery in women is strictly reserved for severe anatomical rescue,
Like what?
like dividing fused tissue so a patient can physically urinate or engage in intercourse. It restores function, but it does not cure the underlying disease.
Which brings us to the frontier of clinical treatment. If the creams fail and surgery guarantees a recurrence, patients are just left desperate. This is why regenerative medicine is becoming the most fascinating space in dermatology right now.
It really is.
Clinics are experimenting with therapies that don't just suppress the immune system, but actively rebuild the obliterated tissue using the patient's own biological material.
Yes, we are looking closely at combination therapies utilizing PRP and nanofat grafting.
Okay, let's break that down. PRP stands for platelet-rich plasma.
Correct. The clinical process involves drawing the patient's own blood and spinning it in a centrifuge. This isolates the platelets, which are incredibly dense with human growth factors.
And the second half of that equation is the nanofat grafting, or lipofilling. They perform a microliposuction, usually taking a small amount of fat from the patient's abdomen or lower back.
Yeah.
But it's not the fat itself they care about, right? It's what lives inside that adipose tissue.
Right, exactly. Adipose tissue is one of the richest sources of stem cells in the adult human body. So the clinic processes this fat down to the nanoscale to extract those cells. They mix the stem cells with the growth factors from the PRP and inject this biological cocktail directly into the damaged vulvar tissue.
So let's break down the mechanics of how this actually heals the skin. How does a stem cell from your belly know what to do when it's injected into a genital scar?
It comes down to cellular signaling and angiogenesis.
Angiogenesis.
Right, so the severe scarring of lichen sclerosus strangles the local blood supply. The tissue is quite literally suffocating.
Okay.
When you introduce the growth factors from the PRP, they trigger angiogenesis, which is the formation of brand new blood vessels. This rushes oxygen and nutrients back into the dead zone.
Oh, I see.
Simultaneously, the stem cells detect the massive tissue damage. They are blank slates that respond to their environment, so they begin differentiating and coordinating the repair of the skin's architecture. They thicken the dermis and break down the rigid fibrosis.
It's basically turning the body's natural healing mechanisms up to 11. And while it is largely considered experimental and, requires out-of-pocket payment since insurance rarely covers it, the clinical outcomes being reported are profound.
They really are.
I mean, there are documented cases of patients who suffered from totally steroid-resistant LS, enduring such severe pain they had to abstain from intimacy with their partners for 7 years.
Hmm.
And after undergoing this regenerative PRP and nanofat therapy, they completely resumed their physical relationships.
It is a stark reminder that we aren't just treating an itch here. We are trying to restore fundamental human connection and quality of life. Regenerative medicine represents a massive paradigm shift for patients who thought they had literally run out of options.
So, synthesizing everything we've uncovered here, betamethasone absolutely works. It is the crucial, potent fire extinguisher you need for maintenance once the ultra-potent clobetasol has put the initial flare-up out.
Yes, and its effectiveness relies entirely on conquering steroid phobia and adhering to the fingertip unit metric. You are not thinning your skin. You are stopping the disease from destroying it.
Right. And if you find yourself hitting a wall, remember to check for secondary issues like yeast infections or explore regenerative options with your specialist. There's always a next step.
There is one final critical reason why establishing this maintenance routine is just non-negotiable.
What's that?
While lichen sclerosus is categorized as a benign autoimmune condition, leaving that chronic inflammation unchecked carries a highly specific danger. Patients with LS have a 2 to 5% lifetime risk of the affected tissue mutating into squamous cell carcinoma, which is a serious form of skin cancer.
That statistic sounds terrifying, but I feel like it should actually be empowering. By adhering to your step-down therapy, utilizing that betamethasone to keep the inflammation at absolute zero, and maintaining regular visual monitoring with your doctor, you are actively neutralizing that cancer risk.
Precisely.
Lichen sclerosus alters your life, but with the right tools, it doesn't have to define it.
It demands lifelong diligence, yes, but the biological mechanisms are highly manageable.
Now, before we wrap up, I want to revisit a detail that completely blew my mind in the sources.
Oh, yeah.
We talked about how surgery fails for women because the disease comes back directly on the new surgical scars. This isn't just bad luck, right? It's a documented biological mechanism called the Koebner phenomenon.
Ah, yes, the Koebner phenomenon. It occurs when an underlying skin disease actively seeks out and manifests on areas of recent physical trauma.
Right, so if a patient had an old obstetric tear from childbirth decades ago, or an old surgical scar, the lichen sclerosus doesn't just appear randomly. It literally uses that old scar as a landing pad. It preferentially attacks the sites of past injuries. How is that mechanically possible?
It comes down to the localized memory of our immune system.
Memory.
Yeah, when your skin experiences a severe trauma, your body sends in T cells to fight potential infection and manage the healing. What we're beginning to understand is that some of those T cells, called tissue-resident memory T cells, never leave. They set up a permanent garrison at the site of the old injury, waiting for the threat to return.
Wow. So when the autoimmune disease triggers a system-wide inflammatory response, those ancient garrisons basically wake up.
Exactly. They become hyperreactive. The immune system's own dark memory of an old trauma acts as a physical map, directing the new disease exactly where to strike. It reveals a level of cellular memory and targeted autoimmune pathology that we are only just beginning to decipher. The body never truly forgets where it was broken.
Which is a beautiful, if, somewhat haunting thought to leave on. Your skin remembers its history, and sometimes the immune system gets confused about who the enemy is. So the next time you open a medication box and see a terrifying warning label, remember the paradox. Sometimes the medicine isn't the danger. Sometimes it's the site manager you desperately need to call off the demolition crew and let the healing begin.